All right, so today on Road to 250, I'm going to talk about DKA. The bug is going to be Mucormycosis and Rhizophus, and then for drugs, I'll talk about insulin. So to start off with our bug, Mucor and Rhizophus. So this is an opportunistic fungi, which means that it likes to take advantage mostly of immunocompromised patients, especially patients who are neutropenic and or have leukemia. But so as it says here, but to start off with more about its morphology, and what most questions really like to test on is what is it characterized as in terms of its shape, or what would it look like under microscopy? It's a hyphae.
So it's 90 degrees non-segmented?
Yeah, exactly. So yeah, it's characterized as having irregular, broad, non-septate hyphae branching at right angles. And like Divya said, 90-degree right angles is kind of the clue that you're going to want to look for. Okay, so Rhizophus is actually a bread mold. So I guess you can get it from that too. But other than that, transmission, what is route of transmission from Mucor/Rhizophus commonly?
This goes through your cribriform plate. So
It does, but before it gets there, yeah, okay. Maybe that'll help you get to it.
So
if it gets to the cribriform plate, most likely is entering through
mucosal membranes?
Yeah, so spore inhalation. So that's kind of how it's transmitted. And then once it's been inhaled, the fungi proliferates in the blood vessel walls, and it penetrates, like Divya said, the cribriform plate, and it enters the brain, which it causes pathogenesis there, such as rhinocerebral frontal lobe abscesses and cavernous sinus thrombosis. So then as symptoms arise, it would be headache, facial pain, and what also is a characteristic symptom on the face?
Black eschar?
Yeah, black necrotic eschar on face, and it might have cranial nerve involvement. So essentially at this point, if you see this on a patient, or if a patient's presenting with a black necrotic lesion on their face, it pretty much means that the patient is going to have a bad prognosis. The infection has deeply penetrated and affected the blood vessels. So, yeah. And then I guess fun question if you want. What nerves go through the cribriform plate? Or what nerve fibers?
Cranial nerve 3?
1, olfactory nerve fibers are going to travel through the cribriform plate. And then last but not least, in terms of treatment, because there's going to be this necrotic lesion on the face, surgical debridement is going to be key. And then in terms of systemically treating amphotericin B or isovuconazole. So yeah, that is our Mucor Rhizophus. Any questions? Okay, so moving on along the topics. So insulin. I'm going to talk about injectables. And so I want to start off by asking you guys, essentially, how are the insulin injectables broken down into in terms of their categories?
By their duration.
Yep. So what are some of those?
Let's see, there's...
You can just blur it out.
Something.
Sorry, what did you say?
Something with a G.
Or not, don't worry about names. What
Lispro.
about just
Oh,
like,
so long acting, short acting,
right,
moderate
exactly.
acting.
Yeah. Yeah, so essentially they're broken down by rapid acting, short acting, intermediate, and long acting. So the rapid acting, that's going to make up Lispro, Aspart, glulisine, and you can remember this with mnemonic no lag, because that has no lag. So LAG, so L for Lispro, A for aspartate, G for glulisine. And like it says, it is rapid acting. So the rapid acting insulins, they are monomeric insulins, and they do not polymerize into hexamers like regular insulin does. And this allows it to be rapidly absorbed into our body. Hence why it is starts working in 15 minutes, and then it peaks 1 hour or within 45 to 75 minutes. The next group, like it says here, is short acting, and this is just called regular. And like it says, its peak is 2 to 3 hours. And that's what I got for short acting. Intermediate acting, this is known as NPH. NPH stands for neutral protamine agadron. And it starts working within 2 hours, peaks 4 to 12 hours, and then lasts about 18 hours. And then the long acting, it doesn't really have, apparently, but according to UWorld, it does start working within 2 hours, peaks between 3 to 9 hours, and lasts up to 24 hours. And this is your detamir and glargine. And so a little bit about detamir is that it has and I guess this concept can kind of be applied to both detamir and glargine in a variation, but essentially they have a fatty acid component added on to the lysine amino acid terminal of the insulin molecule. And this fatty acid side chain essentially then allows binding to albumin in our body, and then it slowly dissociates, hence why it has a prolonged action. And so, yeah, so essentially the mechanism of action overall, insulin injectables are just going to imitate physiologic response to glucose fluctuation in our body. So the long acting is usually given once a day, combined with a rapidly short acting, combined with a rapidly acting injection with meals. So the rapidly acting one will peak levels and then maintain constant for about 2 to 4 hours, and then the long acting one will reach its effective concentration. I'm confusing myself. So the long acting will reach peak levels and then will last 24 hours. And then the short acting one would reach effective concentration from anywhere within 15 minutes and then last 3 to 4 hours. So short acting usually given after meals or with meals before you eat. And then adverse effects, you have to be careful with insulin, as it can really throw a patient into hypoglycemia much easier than oral hyperglycemics. These patients also get lipodystrophy. Does anybody actually know what that kind of looks like or can be described as?
So like fat movement from one spot to another?
Yeah, essentially. So yeah, I had a really interesting question today, and it really described it well. But essentially, the patient, it is like an issue with fat distribution, and the patient pretty much had lost all their fat in their extremities, so like atrophy. Their face had like completely gone down, and then they just had a lot of most of their fat accumulating around their stomach, so it kind of like looked like they just pretty much had ascites. So kind of like what happens in a patient with this lipodystrophy, which makes sense because usually they might be getting their insulin shot in their stomach. So, and then it has rare hypersensitivity reactions in general. So, any questions about insulin or anything anybody wants to add? Okay. So then I can kind of move on to my concept of the day, which is DKA. So I might actually go here first to kind of give you guys an idea or a little bit more of a detailed background about DKA. But essentially what happens is we're looking at patients who are type 1 diabetics for the most part, not to say that it doesn't happen in type 2s, but essentially the lack of insulin. So essentially this patient has a lack of insulin and there is increased glucagon because there is release of glucose in the liver since this patient is becoming like hypoglycemic. And so, so pretty much there's going to be an increase of glucose from glycogen via glycogenolysis. And these high levels of glucose in the body are then causing over saturation in the kidneys, and so it's spilling out, which is also taking the solutes potassium and sodium with it, which is known as osmotic diuresis, hence why the patient becomes hypokalemic, hyponatremic. And then this patient is going to have these symptoms of polyuria, dehydration, polydipsia. And so also with the absence of insulin, because this patient, again, is type 1, they have release of free fatty acids from the adipose tissue. So they're having this lipolysis occurring. And they're going to be converted, these fatty acids are then going to be converted into ketone bodies by beta oxidation in the liver here. And then they're going to be in the form of the beta hydroxybutyrate, which is an acid, hence why the patient is in acidosis. And it's kind of turning the blood acidic as it gets thrown back into the blood. And as our body's way of compensating for that after its normal compensations, we're going to start hyperventilating, or this patient's going to start hyperventilating, and that is to blow off some of the acid. And the hyperventilation then can be characterized as the small breathing or respiration. So to go back here, as it says, usually due to insulin non-compliance or increased insulin requirements. Like I said, there's an excess fat breakdown and increased ketogenesis from increased free fatty acids, which are then made into ketone bodies. And the ketone bodies take a precedence in the form of beta hydroxybutyrate, also characteristic in terms of symptoms as acetone breath in these patients. So usually occurs in type 1 diabetics as endogenous insulin, and as endogenous insulin in type 2 diabetics usually prevents lipolysis. So it's more commonly seen in type 1. So signs and symptoms, DKA, deadly. These patients can have delirium/psychosis, small breathing, which is the rapid deep breathing or the hyperventilation, and abdominal pain, nausea, and vomiting. And they also have dehydration because they have the over saturated transporters of glucose, so now glucose is spilling out into the urine, and water follows glucose too. So body is becoming dehydrated. And the fruity breath odor due to exhaled acetone. So that's our beta hydroxybutyrate. In labs for these patients, they're going to have hyperglycemia, so increased glucose, but no insulin to push the glucose into the cell. They have increased acid from the free fatty acids that made the beta-hydroxybutyrate or the ketone body, so those are acidotic. Decreased bicarb, and they have an increased anion gap metabolic acidosis. So what is an anion gap would be greater than what in order to be considered metabolic acidosis?
15?
Yeah, greater than 12. So, yeah, anion gap. And then in the blood, there will be increased ketone levels, which can be measured. These patients will have leukocytosis, hyperkalemia initially, but then overall, or the total body, is depleted intracellular potassium due to the transcellular shift from decreased insulin and acidosis. So kind of with the whole the osmotic diuresis that occurs, that overall causes the total body potassium to be decreased. Right. Yeah. So increased potassium loss in urine. So total body is depleted. And so complications, kind of what we talked about already. So life-threatening mucormycosis. It's usually caused by the rhizopus infection, and it is a good mucor likes the DKA environment. So that is why it's more susceptible there. And then that can lead to cerebral edema. And then cardiac arrhythmias can occur, especially if we have the depleted potassium. And then heart failure can occur as well. So in terms of treatment, this is very important that we initially give fluids to our patients. So hydrate them because they are dehydrated. And then give them IV insulin. And then potassium is important so that we can replete the intracellular stores, and that will especially then be important in terms of monitoring the cardiac functions when we are replacing the potassium. And then you can give glucose if necessary to prevent hypoglycemia as well when you are giving the insulin, in the case that you have to give a sufficient amount of insulin to replace and to put the patient back into hemodynamic state. But we have to make sure that that's fixed. So in the case that that causes the patient to become hypoglycemic, you can give glucose. So yeah. Any questions or anything anybody wants to add on to? All right. So then I have a couple questions for us. Okay, so a 21-year-old man comes to the emergency department with dizziness and extreme fatigue. He says that he has been drinking a lot of water and urinating more than usual for the past 2 weeks. He developed nausea and vomiting 1 day ago and has had difficulty keeping food and liquids down. The patient has no other medical problems and takes no medication. He does not use tobacco, alcohol, or illicit drugs. His blood pressure is 90/60, pulse is 120, and respirations are 14 breaths per minute. And the patient's urine is positive for glucose and ketones. He is started on IV fluids and insulin infusion. If the type of insulin used for treating this patient's current condition is administered subcutaneously instead of IV, it would most likely produce which of the following curves? And it would just be like A, B, C, D, or E.
B, regular insulin?
Yeah, so yep, it would be B, which is regular. And usually DKA are treated with the regular insulin. It's the preferred type, and it's because it's pretty rapid, so it begins to lower the serum glucose within minutes, and its half-life is about 5 minutes. So the subcutaneous is also a little bit quicker than IV, hence why it will lower the serum glucose within minutes, which kind of sounds like it would be the short-acting, but it's really not. It's just that subcutaneous will allow it for it to become activated within minutes, and its half-life is 5 minutes. So, yeah. Okay. Any questions or anything about that? Okay, so the next one is a 60-year-old man was diagnosed with type 2 diabetes mellitus 6 years ago. His current treatment regimen includes a long-acting subcutaneous insulin injection once a day. Review of his home glucose measurements showed that his postprandial glucose levels are too high. Which of the following types of insulin would be most appropriate to administer before each meal? So A, regular insulin, B, NPH insulin, C, insulin aspartate, D, insulin glargine, and E, insulin detamir.
B, D, and E are long-acting or longer, so you don't want those because he's already on that.
NPH is intermediate, so that's not going to be useful here either.
And that's
right.
Twice a day, so you don't want that.
C.
Yeah, A or C.
Yeah, so it would be C, insulin aspartate, which is rapid. Rapid. So it's more indicated for the postprandial glucose control. So that would be like his short-acting, and then he will always continue or still continue his long-acting sub-Q. And then last one, a 22-year-old pregnant patient has hyperglycemia. On routine blood work analysis, you perform a 3-hour glucose tolerance test, and based on the result, make a diagnosis of gestational diabetes. After 1 week on a calorie-restricted diet, the patient blood glucose remains elevated. You decide to initiate pharmacotherapy. Which of the following medications is the best choice for this patient? A, metformin, B, insulin, C, glibenclamide, D, pioglitazone, E, acarbose.
Metformin?
Yeah,
insulin?
Yeah, so the answer is insulin. And insulin's the best, as it has the least amount of side effects
like
in terms of teratogenicity. Yeah, because metformin, I guess, like, I read that maybe not necessarily metformin, but glyburide or glyperamide have been tested or maybe starting to be indicated as safe drugs too, but for the most part, everything else but insulin can cause the child to also contract hyper or hypoglycemia. So insulin is the best choice, which is what I learned.
Yeah, I think it's dietary first, exercise second, and insulin third.
Yeah.
If everything fails, insulin will be the last choice.
Yeah. And yeah, in this patient, they did like calorie restriction as a option. So, yeah. And like usually in gestational diabetes, when they do the 3-hour glucose tolerance test, it'll normalize within that 3-hour test. But in this case, this patient, it did not. And then they put her on the 1 week calorie restriction and still didn't see a difference. So at this point, insulin was the best option. And